Welcome to the 6th lecture on trauma and orthopaedics for medical students, aimed at covering the core topics for the medical licensing assessment. This lecture is on disorders of the foot and ankle. Most of the topics you'll need to know about are related to trauma, in particular ankle fractures, Achilles tendon ruptures and metatarsal fractures. There are a number of other conditions, both traumatic and elective, that you should be aware of, but you are unlikely to be examined on directly at finals level. As you can see here, this maps to a number of the domains in both presentations and conditions from the curriculum for the medical licensing assessment. The ankle is quite a complex joint, so we have a few slides just to remind you of the basic anatomy, with the structure of the main parts of the joint, with the tibius, the talar and the fibula, with the calcaneus line underneath. The ligamentous structures around the ankle are very important, but you don't need to know them in huge detail. You need to be aware that there is a medial ligament, otherwise known as the deltoid ligament, and a lateral ligament which stabilizes the fibula. For those of you more interested, you can see here the arrangement of the ligaments and note the interosseous membrane which lies between the tibia and the fibula, as this is also important in ankle fractures and dislocations. Ankle fractures are common, and they can occur in any part of any of the bones associated with the ankle joint. Here is a fairly broad definition, and you should just note that if the tibial articular surface is involved, this is what's called a pilon fracture. As with all fractures, the presentation is fairly simple. There's severe pain and the patient will be unable to walk. The physical examination is what you would expect with a fracture. There will be swelling and bruising around the ankle. It could be on the medial side, it could be on the lateral side, and there may well be deformity. You should palpate up around the fibula for what's called a mesonerve fracture, where there is a soft tissue injury that runs up through the interosseous membrane. You do need to have a look at the soft tissues for what's called fracture blisters, skin tenting or any open wounds. Typically, motion is limited due to pain, and you should assess the neurovascular status and just check about diabetic neuropathy. Imaging is usually in the form of X-rays, and there is an ankle series, and you should certainly consider a full-length tibial view to look at the knee joint for the mesonerve injuries. In the less acute setting, you may want to do a weight-bearing view to look at instability. CT scans are sometimes required if you want to look at the joint surface itself, and occasionally MRIs, but these are a little bit more specific. This is an example of a standard AP and lateral of the ankle, and you can see on the fibula a small undisplaced fracture. As you'll remember from the fracture series, these X-rays are covered in more detail there. You need to be aware that, as with all fractures, there is a classification, but you don't need to know too much about it. Typically, the Weber classification is used, with a type A fracture being below the level of the syndesmosis, a type B fracture being at the level of the syndesmosis, and a type C fracture being above the level of the syndesmosis, as seen in the diagram here. Treatment can be non-operative or operative. The non-operative indications are if ankle fracture is deemed as being stable, or if the fracture is at the very tip of the medial or lateral malleolus, or a very small posterior malleolar fracture, or obviously if the patient is unfit for surgery. As you would expect, the indications for operative management are the opposite of this. So if there's displacement, if the fracture is obviously unstable, or if there's a fracture that runs up through the ligaments, all of these will need to be treated operatively. If we move on to Achilles tendon ruptures, these are very common, particularly in the middle-aged athlete or person undertaking sports. They're usually traumatic, either with a forced plantar flexion, as in pushing off and sprinting, or if the ankle is violently dorsiflexed, which is less common. The patient typically describes a pop and a pain that occurs acutely in the back of the ankle, and they'll often describe a feeling as if somebody's kicked them in the back of the ankle. They'll have difficulty walking and localized pain. The clinical examination is fairly classic. There is the increased dorsiflexion of the ankle in the prone position with the knees bent. There will be typically a palpable gap in the Achilles tendon, which may be tender, and they will have weakness in plantar flexion and often increased passive dorsiflexion. There is the Thompson test and the Simmons test, which is a lack of plantar flexion when the calf is squeezed. When imaging the Achilles tendon rupture, typically an X-ray is taken just to rule out other pathology or fractures. Ultrasound is the most common modality, as this will identify complete or partial ruptures and will give you information about how far apart the ends of the tendon are. MRI is less commonly done and is really only if there are chronic injuries or the diagnosis is really uncertain. The majority of these injuries are treated non-operatively with either functional bracing or casting in an equinus position. This can be done in a cast or in a walking boot with heel wedges, which are sequentially removed to bring the foot back into the neutral position. It is important that DVT prophylaxis is undertaken due to the prolonged immobility of the lower limb. It is occasionally necessary to treat these operatively, and there are a number of different ways of doing this, which can be through an open incision or through percutaneous techniques, and occasionally in chronic cases it's necessary to lengthen the tendon to bridge the gap. Fifth metatarsal base fractures, this is otherwise known as the Jones fracture, are one of the most common fractures of the foot and have a habit of not uniting. Typically the mechanism is one of planting the foot and then inverting, so twisting it in, or pulling it straight across towards the midline, which can both cause a fracture, and occasionally a microtrauma, repetitive microtrauma, such as in walking or marching, can give you the zone 3 injuries. So typically the presentation is either of an acute twisting injury to the foot or a more chronic pain, particularly relating to an increased workload, so more running, more walking, that sort of thing. The symptoms are of pain over the lateral border of the foot, particularly when weight bearing. The clinical examination starts with inspection, and often there isn't a lot to see. There may be some slight alteration in the way the foot is held when weight bearing, and in a chronic case there may be excessive wear on the shoes, which is asymmetric, but often there isn't much to see. Typically there's pain on eversion of the foot when it's stressed. Typically the imaging is of X-rays, and you can ask for a foot series, which is an AP, a lateral and an oblique view of the foot. This should show the fracture up. In chronic or uncertain cases, a CT scan is done, and very rarely MRI. Treatment can be non-operative, which is protective weight bearing in a stiff shoe or a boot, and occasionally non-weight bearing in a short cast, again protecting against DVT. Operative treatment is reserved for either those fractures which it is felt won't unite, or those that have failed to unite, and this can be done either with a screw straight down the middle or a plate and screws through a slightly larger incision. As was mentioned at the start of this lecture, a tibial plafond fracture, so a fracture of the base of the tibia, is otherwise known as a pilon fracture. These are often quite comminuted, so multifragmentary, and obviously they involve the joint itself. They are significant injuries because there is a lot of soft tissue trauma, and they're typically caused by high energy injuries. These patients will present quite differently to the average ankle fracture in that they will have much more severe pain, and they definitely will not be able to weight bear. There is also usually much more of a history of significant trauma. The physical examination will be quite different to the other ankle fractures. There will be much more swelling, quite possibly fracture blisters, and their ankle motion will be almost nothing due to pain. It's important to look for other injuries with these because of the nature of the mechanism. So do check the pulses, consider looking at the knee and the hip as well. You might need to consider doing some vascular studies, and you need to think about compartment syndrome in the lower leg because of the much greater mechanism of injury in these fractures. As with all injuries, plain X-ray is the first way to go. However, these may well be part of a trauma series and will go straight to a CT, but certainly CT scanning is needed for preoperative planning, as these are quite complex fractures. These plain X-rays and the CT scan show the extent of the injury and the damage to the bones involved in these fractures, and the necessity for some quite complex surgery to reconstruct everything. In your answer to any management of fracture, there is obviously a non-operative option. These are quite rare because these fractures essentially are not stable. It may be that if you have a non-ambulatory or a critically ill patient, it's not appropriate to operate. And sometimes if there are significant skin problems such as diabetics or people with vascular problems, it may not be appropriate to operate, but these are rare. The vast majority of these injuries do get treated operatively, but they are complex. There are a number of different ways of dealing with them, dependent on the nature of the fracture, the age and other comorbidities of the patient, and what the skin looks like. And it may well be that they have a temporary operation, what's called a spanning external fixator, and then more definitive surgery later on. Sometimes it's necessary to actually fuse the joint because it's not possible to reconstruct it properly. Moving down more into the junction between the ankle and the foot is the talus, and this is the second most commonly fractured tarsal bone, typically again by a fall from a height or road traffic accidents where the foot is forced into dorsiflexion. As with all fractures, the patient will present with severe ankle pain, there may be deformity, and they will certainly not be able to weight bear. As with the other injuries around the ankle, the inspection will be of ankle tenderness, there may be swelling, there may be abrasions, and there may be fracture blisters which develop after a few hours. It is important to look for open wounds and to look for other injuries, as these are, like the plafond injuries, more high energy. It's also important to check the neurovascular status and consider compartment syndrome. As with the other injuries, plain X-rays are the first investigation, but this probably won't show you much apart from the fact that there is something wrong, and CT really is the way to go to look at the articular involvement, the displacement, and to plan the surgical approach. Fractures of the talus, like all fractures, can be classified. This helps with surgical planning and enables you to start to predict the risk of avascular necrosis, because this is one of the bones that has an unusual blood supply and therefore risks AVN when fractured, but you do not need to know the classification for finals. Treatment can be non-operative, but in the first instances everything has to be reduced, so everything has to be lined up. And really the only indication for non-operative treatment of these is in undisplaced fractures or in patients who are not suitable for surgery. The vast majority will undergo open reduction and internal fixation with the aim of restoring the articular surface and restoring the anatomy to maintain the blood supply. As I mentioned previously, one of the concerns with talus fractures is the risk of avascular necrosis. You do not need to know in detail the anatomy of the talus or the anatomy of the blood supply. Just be aware that it has this retrograde blood supply, and if you damage it, it is one of the bones that risks AVN. If we move on to the last of the injuries around the foot and ankle, this is the Lisfranc injury. Again, you need to be aware of it, but you do not need to know it in any great detail. So this is actually a fracture dislocation of the junction between the tarsal bones and the metatarsal bones. It's usually the result of a fairly significant injury, which may be a fall from a height or even a crush injury to the foot. The presentation, like all of these, is of significant pain and inability to weight bear. The examination of these patients, you will often see some bruising over the medial plantar aspect of the foot. There will be a lot of swelling, tenderness in the midfoot, and inability to weight bear. There are a lot of provocative tests you can do, but you do not need to worry about these. As with the other injuries, the first investigation is an X-ray, and again, often this will show you the diagnosis but won't give you all the detail you need, and therefore CT scans and sometimes MRI scans are more appropriate. You can see here on these X-rays that there is a dislocation of the whole of the forefoot from the midfoot in all of the views, but it can be difficult to get the fine detail. Again, these are significant injuries and the majority are treated surgically. There are obviously indications for non-operative treatment, which is non-ambulatory patients or those with significant vascular disease or neuropathy. There are a number of approaches to the operative treatment, but basically the principles are to reduce everything to line it up and then to stabilize it, and this is typically by fusing the tarsals and the metatarsals together. If we look now at a few of the more common non-traumatic conditions, the first one is plantar fasciitis, and this is a painful condition of the heel and the plantar aspect of the foot caused by inflammation of the plantar fascia, typically as it inserts into the calcaneum. The condition is characterized by quite severe pain in the region of the heel and the plantar fascia as it attaches to it. Often the patients don't like to load the heel, so they'll tiptoe, and it gets worse by the end of the day, although it does seem to be eased as they walk, and often it occurs in both feet at the same time. On examination, there's not much to see, but there is usually point tenderness just at the calcaneum, at the insertion of the plantar fascia. If you dorsiflex the ankle and the toes, that can reproduce the pain, and often they have quite a tight Achilles tendon. Initially, in a lot of these patients, no imaging is needed, and you can start treating based on the history and the clinical examination. However, sometimes X-rays are useful, MRIs can be useful in the rare cases you have to operate, and very rarely bone scans if you're concerned about something like a stress fracture. The vast majority of plantar fasciitis is treated non-operatively with pain control, stretching, sometimes some nital phoces to dorsiflex the ankle. Occasionally shockwave treatment, that seems to work, but can take a few weeks. And sometimes steroid injections, but these are less common. Rarely operative treatment is needed, and there are a number of things that can be done here with either local surgical release or effectively lengthening of the gastrocnemius muscle. The other condition, which is very common that you should be aware of, is hallux valgus or bunions. This is quite a complex deformity involving the first ray of the foot, which is majority genetic, and there is a family history, but can be related to other conditions such as rheumatoid arthritis, cerebral palsy, and as we know, it can be related to footwear. The presentation is usually fairly clear. The patients will complain of a slowly progressing deformity in the foot with the bunion. They can complain of pain when walking and difficulty wearing particular shoes as a result. The basic physical examination of hallux valgus is fairly simple, as you'll see the deformity and you'll see the slight pronation as a consequence. If you get more involved in foot surgery, there are a number of things that you have to do to look at the causes of hallux valgus, but for most purposes it's simple enough just to inspect and identify the pathology. Essentially, all that needs to be done with imaging of these is to take x-rays, both the standard views and weight-bearing views, at which point a number of measurements can be made, but you do not need to worry about the details of this. In the first instance, the treatment is non-operative. It may just be simply a cosmetic deformity, and it may be that you need to give advice about modifying shoes, wearing slightly wider shoes, possibly padding, and this is all that is needed for the majority of patients. Occasionally surgery is required, and there are a number of surgical options which involve realigning the bone and reducing the deformity. They're listed here for completeness, but you really don't need to know anything about any of them at this stage. The next condition is arthritis of the great toe metatarsophalangeal joint, otherwise known as hallux rigidus. And this is characterized by pain and a loss of flexion extension of the joint due to arthritis. Typically, the cause is traumatic, high impact sports loading the joint. The patient will present with pain over the metatarsophalangeal joint. They may have swelling, they may describe the altered gait because they don't want to load the joint, and they may struggle with some shoes as a consequence. On examination, there may be swelling of the first metatarsophalangeal joint. There may be a prominence over the dorsum of the foot due to an osteophyte. There may be some skin irritation if the shoe's been rubbing on it. And when you examine them, there is limited range of motion with pain. And you may find that they load the outside of the foot in preference when they walk due to pain. Imaging most of the time is simply with x-rays, and you'll be able to see the osteophytes on the dorsum of the foot. There may be joint space narrowing and subchondral cysts, as you see in any arthritis. Occasionally, in early stages, you might want to get an MRI, but this is quite rare. Again, with As with all conditions, the treatment in the early stages is non-operative with non-steroidals. Consider activity modification. You can use an orthotic which stops the foot from dorsiflexing too much, and in acute situations you can consider a steroid injection into the joint. If the conservative measures don't work, you can consider a number of operative interventions, either to trim away the osteophytes or to do some form of osteotomy, a fusion, or occasionally even a replacement. The final condition we'll consider is the Morton's neuroma. And this is a compressive neuropathy of the interdigital nerve that runs between the metatarsal heads and can lead to predominantly plantar forefoot pain. The diagnosis is really a clinical one, with tenderness over the plantar aspect, really of the web space between the metatarsal heads, with often a palpable neuroma, and when the heads are compressed, you can get a click, and usually no investigations are needed. The non-operative treatment is with what's called metatarsal pads and wearing shoes that are slightly wider to reduce the compression. If the symptoms don't resolve, then you can treat these surgically with excision of the neuroma and decompression of the web space. This brings us to the end of this lecture on foot and ankle conditions for the medical licensing assessment. As you'll have seen at the beginning, most of what you need to know is about fractures around the foot and ankle, and we've included the other information really for completeness of your education, but you're unlikely to be examined on it in any detail at finals. We hope you found this useful and that you enjoy the other lectures in the series.